Bismillahirrahmanirrahim. Assalamualaikum. I'm Dr. Shasya Kulsoom. I'm pediatrician, pediatric neurologist, and today I will talk on a status epilepticus, which is very important topic. So I will try to sort out the answer of what is a status epilepticus and why this status occur, how it affects the human body and different human system, and how it was defined and what are the recent guidelines. So we will try to find out the answer of what, why, how, and now. So what is a status epilepticus? If we say as in a common language, status epilepticus is basically a abnormal brain discharge, and to define it accurately in a medical terminology, it has goes through various phases. So how it was defined in our old definitions, it was defined as a convulsive seizures, the seizures which is having a motor activity like limb jerking. Either that seizure could be a single or multiple, and it was lasting for a more than 30 minutes. So remember, more than a 30 minutes, the convulsive seizures of a more than 30 minutes, it was one of the old definition. Then this definition evolved, and it was decided if the convulsive seizures of single or multiple, and it lasts for a more than 15 minutes. So the time duration was reduced. Then again, the single, instead of a single seizure or a multiple seizure of a prolonged duration, it was decided a series of a seizure in which there is no complete restoration of consciousness is a status epilepticus. So these are the old definitions of a status epilepticus. So seizure of a 30-minute duration, then revised of a 15 minutes duration, or of irrespective of duration, the seizures without restoration of consciousness is defined in an old definition as a status epilepticus. And the current definition is, it is revised. So I will let you know why the revision was required. So if a seizure, if it is last for more than 5 minutes, is defined as a status epilepticus, or 2 or more discrete seizures, whatever the duration is, but if there is a no recovery of consciousness in between, is called as a status epilepticus. So either if the seizure is of 30 seconds, 15 seconds, or 2 minutes, and the seizure is stopped but child do not recover completely its normal mental alertness, and then the second seizure occurs, this is called as a status epilepticus. And to add on more, to decide the treatment, any seizures, any child who is brought to the emergency room with seizure should be treated as a status epilepticus regardless of the prior duration. So in upcoming slides we will discuss what is the importance of reducing this time duration. So in this slide, which is depicted on a screen right now, the International League Against Epilepsy in 2015 revised the definition of a status epilepticus, and here I would like to discuss about the words which are depicted in red, the time point 1, which is a 5-minute duration. So any condition in which there is the failure of mechanism which is responsible for a seizure termination, or the initiation of any mechanism which leads to the abnormally prolonged seizure of time point 1, which is the 5 minutes duration. So The reason of this timeline is that it was noticed the initial definition of status, which was about 30 minutes or 15 minutes, and this was found that this prolonged duration of status epilepticus duration leads to the irreversible damage already. So then it was required to act early. So in a research base, it was found that for the first 5 to 10 minutes, it's easy to control the status rather than give a prolonged duration of 30 minutes. Why? Because a condition that can lead to a long-term consequence, the time point 2. So beyond 30 minutes is the irreversible damage to occur. Irreversible damage in a way of neuronal death, neuronal injury, or change in a function of neuronal network. So status epilepticus is, as we discussed, is any seizure of a more than 5 minutes duration, or a 2 discrete seizure in which there is no complete recovery of consciousness, or any child who brought to the emergency department with the active seizure is treated as a status epilepticus. The status epilepticus can be a refractory, right? So we call as a refractory status epilepticus when it does not respond to the adequate dose of emergency and urgent medication. So this refractory status is status which can be a clinical convulsive status or electrophysiological on the EEG recording, right? So any seizure which persists beyond the 30 minutes is now called as a refractory status epilepticus. And status epilepticus can be a malignant status epilepticus, which is a severe variety of refractory status epilepticus. Usually it persists more than 24 hours and it does not respond to a aggressive treatment with anesthetics agent also. So the medication terminology which we use for the treatment of status epilepticus is emergent medication to abort the status, and really the 3 common drugs are used for this emergency situation, which is benzodiazepine, lorazepam, diazepam, and midazolam. And emergent medication, the urgent medication, the classical prototype anti-epileptic, which include the phenytoin, phenobarbital, and valproic acid, levetiracetam. And the refractory medications are usually anesthetics agents. So why it is important to know about the status epilepticus? So we discuss about some epidemiological data about the status epilepticus, which shows that it is a common condition, right? So here is the data of US, which shows in adult population the occurrence of status epilepticus occurs 40 per 1 lakh adult per year. And why it is important for a pediatric patients, for a pediatric, because the large number of status epilepticus occurs in the pediatric age group. So if we compare, it is 5 times of the adult population. So for the first year of life in an infant, the status occur about in 147 per 1 lakh children for the first year of life. So it's 147 per 1 lakh infants, which is about 5 times of the adult population, and majority of the status in children occur during the first 5 years of life, almost around 64 to 85%. And as we all know, the pediatric age group is ranged from the first year of life to the 18 year. So 64 to 85% of the status epilepticus occur in the first year of life. There are so many reasons behind this, and because of a alteration in the functional capacity of pediatric neuronal network, and the reduced threshold of status epilepticus in children, right? So the most common status epilepticus which occurs in children is the febrile status, which almost account for 25 to 40% of the cases. And the very important slide which shows the common etiological factors or common trigger for status epilepticus. The most commonest among that is a fever. Fever could be due to any cause. The most common cause in our scenario is infection, and which is the 36% cause of status epilepticus. And the change in the drugs and the metabolic causes like hyponatremia, hypoglycemia, hypocalcemia, inborn error of metabolism, the congenital causes like neuronal migration disorder, structural malformation, cortical dysplasias, and porencephaly, schizencephaly. So there are so many causes of congenital malformations which leads to the status epilepticus. Anoxia, it could be a birth anoxia, and anoxia due to so many other causes, and there are the long list of other causes of status epilepticus. So few antibiotics can leads to the status epilepticus, like penicillin, isoniazid, ciprofloxacin, and so on. Many anesthetic drugs can be the cause of status epilepticus, like halothane, fentanyl, ketamine, and other psychopharmaceutical like antihistamines, antidepressants, and so on. So what is the cause of status epilepticus? Why the status not occur in a routine? Because normally the balance is maintained between an excitatory and inhibitory neurotransmitter. So if we recall that there is a loss of control of phenomena which leads to the termination of seizure, or there is stimulation of the phenomena which leads to the seizure. So either there is a reduced inhibitory neurotransmitter, or either there is an increase in excitatory neurotransmitter, leads to the status epilepticus. So inhibitory neurotransmitter, if reduced, like a drugs, penicillin, or certain anti-epileptic drugs, sudden tapering of anti-epileptic drug, when there is reduced in inhibitory neurotransmitter, there is a status. Or excitatory neurotransmitter, anything which leads to the excitatory neurotransmitter leads to the status epilepticus. So commonly the inhibitory neurotransmitter is GABA and the excitatory is glutamate. So this is a very important slide which we need to understand, that as we recall, the status epilepticus has been changed in definition. So initially it was a 30 minutes duration, 15 minutes duration. Now it's reconciled to the time duration, the time one of about a 5 minutes duration. So status epilepticus is having a stages, and the early phase, which is the stage 1, the stage 2 is the established phase, stage 3 is the refractory phase, and the stage 4 is super refractory or a malignant phase. So why these stages and with this timeline is important? Because early the management, good the control is, and less of the multi-organ involvement, and consequences are not irreversible if it is early control. So early phase of a status epilepticus is the first 5 to 10 minutes. It is called as an impending status epilepticus or premonitory status epilepticus. this and this is the time period in which we use emergency medicines to stop the status, to abort the status epilepticus. These emergency medicines are benzodiazepines like midazolam, lorazepam, and diazepam. The commonly available is diazepam and midazolam. The lorazepam is not available in an injectable form. And then the second stage of status epilepticus, which is establishing status epilepticus, 10 to 13 minutes. This is the phase of status epilepticus in which the compensatory mechanism of human body is yet functional. So the long-term consequences or irreversible consequences are yet not occurred. So one should have to intervene in a premonitory or phase 1 stage of status epilepticus or establish status epilepticus. Beyond that, the control of status epilepticus is difficult, or if it is controlled, the consequences are permanent. Stage 3 is refractory status epilepticus, which is stuporous status epilepticus, and its time limit is beyond 30 minutes, 30 to 60 minutes. And this is the reason that the classification and definition of status epilepticus was revised, because in the earlier definition the time limit was at 30 minutes, and it was found in a surviving patients that they have, a majority of them have a long-term consequences, right? Because the neuronal damage, neuronal death, or network functioning alteration has already occurred beyond that time. So stage 3 is a refractory status epilepticus. Stage 4 is super refractory malignant status epilepticus, severe form of the status refractory status epilepticus. So this is the stage in which the convulsions continue despite the treatment with anesthetics for more than 24 hours. So what happened in a human body if the seizure persists? If for the first 30 minutes there is a compensatory systematic changes, there are decompensatory systemic changes which can lead to the multi-organ involvement and a bad consequences of death. Okay. So for the first 30 minutes, as we discussed, there are compensatory changes, right? So and then beyond that are decompensatory phase, right? So the two phases of systemic response to status epilepticus. In the first phase, what happened? There is increased catecholamine surge, increased cardiac output, increased cerebral blood flow, increased glucose in the brain, because the metabolic demand is also increased because of a persistent sudden burst of the neuronal discharge. So the brain cell require more energy for this high metabolic demand, and this is compensated for the first initial compensatory phase. So the cerebral energy requirements are matched with the oxygen supply and glucose. So whatever the requirement is, that is provided by the compensatory mechanism. But if it is status persists beyond that 30 minutes, it leads to the decompensation. What happened then? The cerebral autoregulation failure. So increase intracranial pressure, the metabolic problem, hyponatremia, hypoglycemia, hyperkalemia, hypoxia, hypoglycemia, leukocytosis, hypotension, decreased cardiac output, DIC, multi-organ involvement. So one should act early during the compensatory phase to stop the status and stop the development of decompensatory phase. So what is the systematic response of status epilepticus. It commonly affects all body system, but the most commonly involved systems are the respiratory system and the cardiovascular system. So in a respiratory system, if the status persists, it leads to the hypoxia and hypocardia. So poor ventilation. Why? Because of chest rigidity. The continuously muscle contraction leads to the spasm. So it leads to the poor ventilation. Metabolic problems occur because oxygen consumption is increased throughout the body, and carbon dioxide production is also increased. So the poor handling of the secretions due to continuous convulsions. So it is this is another factor for hypoxia and hypercarbia, neurogenic pulmonary edema. So any seizure, any status with hypoxia is more dangerous than seizure without hypoxia. So hypoxia, anoxia leads to the significant increase in mortality. So this is the respiratory involvement with the status epilepticus. If it does not stop immediately, it leads to the hypoxia, hypercarbia. Hypoxia and hypercarbia is having an increased risk of mortality. So status or a seizure with hypoxia is more dangerous than a seizure without hypoxia. And this emphasizes the oxygen inhalation, or when ABC was managed, the giving oxygen to a patient who reached to the ER with status. What is the cardiovascular involvement of a status epilepticus? So as we discussed in previous slides, that the early manifestations leads to the sympathetic overdrive, and sympathetic overdrive lead to the increased heart rate, tachycardia, high CVP, central venous pressure, hypertension, and the late manifestations are there is exhaustion, right? So the exhaustion of this sympathetic drive, which leads to the bradycardia, hypotension, hypoperfusion. So this is very important slide which needs to be learned. So what are the cerebral hemodynamics when there is a seizure? So this is the timeline in x-axis. So when the seizure is started, what happened? This black line indicates that the oxygen requirement increased, and because of a compensatory mechanism, this blood flow is also increased as shown in a red line. But after a certain time point, the oxygen requirement remain high, but because of a decompensation, this red line declined. That means the blood flow reduced to the cerebrum, the brain, and as due to compensation, this blue line represents that the blood pressure initially increased. It remained increased for the first few minutes. Then there is a decompensation, so there is a decline in a blood pressure. So blood pressure, blood flow reduced, but the oxygen requirement remained high. So initially in a compensative phase of cerebral hemodynamic, which is a hyperdynamic phase, the cerebral blood flow continuously exactly the same of cerebral metabolic requirement of oxygen. So in a hyperdynamic compensatory phase, CBF, cerebral blood flow, meets the CMRO2, but in exhaustion phase, the cerebral blood flow drops, hypotension sets, autoregulation exhausted, and then what happened, which is shown in a red bar, that the neurological damage occurs. So this damage can be in the form of cell death, cell injury, or alteration in a cellular network of brain. So functional capacity can be changed. What are the biochemical indicator of status epilepticus? So the blood leukocytosis, which may develop in a 50% of children, and even in a lumbar puncture, CSFDR leukocytosis can occur in few percentage of children. So because of a continuous seizures, the potassium can be increased due to muscular breakdown. So the potassium from intracellular compartment comes out in an extracellular compartment. Similarly, because of persistent spasm muscle contraction, there is increased CPK, myoglobinuria, which can lead to the renal shutdown, and there is increased cerebral pressure, stress, cardiomyopathy. Due to continuous contraction, there may be a bony fractures. Right? So there are certain investigations which can be done, so the intervention can be done to counteract the effect of status epilepticus. So in blood, complete blood count, glucose, calcium, magnesium, UC, LFT, ABG, CSF biochemistry, urine DR, microscopy, CT, EEG. So what to treat? So one should remember this, the time is important. As we discussed in a revised definition of status epilepticus, it is defined now a 5-minute duration, because we learned this, that with a continuous seizure there are so many irreversible damages, right? And as the seizures continue, it leads to the difficulty in control. So early to intervene, the time is important. So quick treatment of status epilepticus is the key. Higher the efficacy of anticonvulsant, better the outcome. Every minute delay in a treatment of a status epilepticus leads to the 5% cumulative increase in a risk of having a status epilepticus lasting more than 60 minutes. That means a status of malignant type, refractory status. So this is the same timeline phase which is depicted in arrows, right? So one should act within 5 minutes, give emergent medicines, right? And which is the time 1, T1. Beyond T2, there is the higher chances of conversion of status epilepticus into malignant or refractory status epilepticus. What are the key components of management? Initial stabilization, the ABCD, respiratory and cardiovascular support. Give the adequate doses of emergent medication and then urgent medication. Identify and treat the underlying cause. As we discuss in etiology, the fever is the most commonest cause. Among the other causes, the metabolic causes can be the reason. Pharmacotherapy for seizure termination, and identify and treatment of underlying cause. Identify and treat systemic complications like hypoxia due to respiratory issues, ventilation perfusion mismatch. So give oxygen inhalation, right? Or systemic complication like hypotension, give IV fluid resuscitation, or inotropes of course if required sometimes, and the neuroprotective measures. So these are the 5 important categories of management of status epilepticus, which include initial stabilization, drug therapy for a termination of seizure, the pharmacotherapy which included emergent and urgent medication, identifying treatment of underlying cause, identify and treat systemic complication, and neuroprotective measures. For 0 to 10 minutes timeline, what we have to do? We have to manage A, B, C, airway, breathing, circulation, and it's recommended to place the nasogastric tube if it is not already inside tube, because of the risk of aspiration, choking, and secondary to vomiting. And decide about assisting ventilation when there are chances of hypoxia. Close monitoring is required and investigations. So emerging medications, as we talked about, midazolam or diazepam or lorazepam, one may repeat it every 5 minutes to avoid the seizures, right? And then urgent medications are the classical anti-epileptic, which is levetiracetam and phenytoin. That should be started immediately after, when the seizure is not aborted by an emergent medication. So if child is convulsive status epilepticus, it is recommended after the start of urgent medication and beyond 10 minutes, but it can be intubation can be done earlier if there is clinical indicator of hypoxia, right? So if seizures continue more than 30 minutes, one give emergent medication to stop the seizure, and then one start with the urgent medication. Give the loading dose of these medication, which is commonly used a classical prototype of anticonvulsants: injection phenytoin, injection levetiracetam, phenobarbital. If the child is having a fever, give antipyretic, continue strict monitoring. Metabolic causes should be identified. So if there is hypoglycemia, the blood glucose should be corrected. Hyponatremia, it should be replaced, sodium should be replaced. Hypocalcemia, give IV calcium, right? So another urgent medication is valproic acid, which can be given, and particularly for children of less than 2 years of age, IV pyridoxine is required, because it is found that the pyridoxine dependent or deficiency status epilepticus is common, or one of the entity in a children less than 2 years of age. Okay. And one important thing, if the patient is known epileptic and already taking certain medications, it is better to give the urgent medication, loading dose of the same medication that the child is already taking. Suppose if the child is already on a valproic acid, it is good to give the loading dose of valproic acid rather than a levetiracetam or phenytoin. Okay. So beyond 30 minutes, if the status epilepticus is converting into a refractory status epilepticus, so continue start with the anti-epileptic or proceed to a pharmacological coma. Right now, this status is turning into refractory status epilepticus, which is difficult to control, so which required a large number of urgent and emergent medications plus induction of midazolam or pentobarbital hormone. And for this status, the continuous EEG monitoring is required, invasive hemodynamic monitoring is required. So commonly required medications is midazolam, phenobarbital, or that anesthetic agent, right? So the most commonly used is midazolam for a refractory status epilepticus. It should be given in a bolus 0.2 mg per kg. Then the infusion is started for 1 to 2 microgram per kg per minute. It should be continued till the seizure is stopped or electrophysiological burst suppression pattern achieved, or till we reach the maximum dose. And we have to continue the midazolam coma for 24 hours of a seizure free interval. Then we start tapering on it. Okay. And with the midazolam coma, this is important to continue on medication drug, right? जो हमने अर्जेंट मेडिकेशंस जो है वो शुरू की थी लॉन्ग टर्म में, क्लासिकल एंटी एपिलेप्टिक वो भी साथ चलेंगी. So other options for anesthetic agents are thiopentol, propofol, ketamine, ibuprofen. What are the neuroprotective measures which we learn in a management? So neuroprotective ये है कि oxygen saturation should be kept more than 94%, volume status should be a normal volume, right? So hypotension has a bad consequences, decreased cerebral perfusion, so euvolemic state should be maintained, and hypovolemia and hypotension should be avoided. Better to keep the systemic blood pressure at the 90 or 95th percentile. So the partial pressure of PCO2 should be maintained 30 to 35. Higher the PCO2, it leads to the vasodilation and raised ICP as we all know. Sodium should be maintained on a higher level. Head and neck position should be at 30 degree. Why? Because it increases the cerebral venous drainage and reduce the chances of raised ICP. So, and temperature should be of 33 or 35 degrees centigrade. Glucose is in a normoglycemic level, not hyperglycemia, not hypoglycemia. So what is the prognosis of a status epilepticus? It has 3 to 10% mortality, and it depends on the duration of the seizure. There are chances of subsequent epilepsy, 20 to 40% chances of secondary epilepsy following the status epilepticus, and in 6 to 15% of the children encephalopathy like change in cognitive stage, learning deficiencies, hearing and visual problems हो सकते हैं. Focal neurological deficit in 9 to 11% of patients, and refractory status occur in 26 to 28% of patients. And obviously when the status is refractory, its prognosis is not good and its long-term consequences are more. So what is the conclusion? Aggressive therapy is required for the management of status epilepticus, as prolonged seizures are less responsive to therapy. The longer you wait to administer anticonvulsant, the more anticonvulsant you will need to stop seizure. The prognosis of patients who have a status epilepticus depends not only on the underlying cause but successful treatment of the seizure. So what is the important message? Act fast, intervene early, intervene during the impending status epilepticus state. When it is established status epilepticus or when the decompensation occurs, it is difficult to control and having a more bad consequences. Thank you.